Hi, everyone. My name is Josh Fox Fuller, and we're pleased that you could be joining us for today's No Neuropsychology lecture series. The No Neuropsychology Didactic Series is featuring several different volumes of 12 lectures over the course of 12 weeks that brings different talks from different experts in the field covering a variety of different interests in clinical disorders, professional development, practice issues, and research. The No Neuropsychology Didactic Series was created by trainees, early career neuropsychologists to provide free, high-quality didactic opportunities. We'd like to thank our sponsors for their continued financial support of our series. And before we begin with today's lecture, we have a few disclaimers, which are presented here on the screen. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Today, questions can be submitted to the Q&A box in the lower left of your screen, and a recording of the lecture will be provided later on their website this week. I encourage you to submit questions to the Q&A throughout the talk. Dr. Parsons will be taking lectures at various different times, so we'll pause and see if we have any questions. So without further ado, it's my pleasure to introduce Dr. Michael Parsons for today's lecture. Dr. Parsons is a clinical neuropsychologist in the Pappas Neuro-Oncology Center in the Department of Psychiatry at Massachusetts General Hospital. His clinical research activities focus on the cognitive and behavioral consequences of cancer, including both brain tumors and non-central nervous system cancers. He provides neuropsychological evaluations for adults with cancer, addressing the cognitive issues that are caused by cancer and its treatment. His research involves the use of cognitive assessments and advanced brain imaging techniques to understand how cancer affects neural systems and the efficacy of treatment for these problems. Dr. Parsons is the author of numerous peer-reviewed manuscripts and book chapters related to these issues and serves as the co-president of the Neuro-Oncology Special Interest Group of the International Neuropsychological Society. Dr. Parsons is also a diplomat of the American Board of Clinical Neuropsychology and the American Board of Professional Psychology. So without further ado, I'll turn things over to Dr. Parsons, and thank you so much for joining us today.
Well, thank you, Josh, Katie, and Annie, and everyone else on the No Neuropsychology group for inviting me to present today. It's an honor to be talking with this group, and a real pleasure for me because as you said, this is my topic of interest and an area where I feel like ongoing education, information for neuropsychologists at every level, but particularly at the early career level, is extremely important and going to be an important part going forward. I need to just reshare my screen here, sorry. Just gonna set this up. So as I said, I'm excited to be talking to you about neuropsychology in neuro-oncology settings. And I'm going to try to cover, I do have a couple of disclosures here. I'm going to try to cover two main topics in differing degrees of depth. This is a broad area, and there's a lot of different topics we could talk about today. We certainly can't cover all of them in the kind of depth that I'd like to, and I've chosen a couple of main points to focus on here. I'll start by talking about cognitive issues in non-central nervous system cancers, or what's commonly known as chemo brain. Most people think of this as the cognitive side effects of cancer treatment, but as I'll touch on, there are also reasons to believe that cancer itself induces some mild cognitive issues. And my primary goal there is to touch on the neuropsychology literature and the cognitive neuroscience literature to give you a basis for understanding the kinds of cognitive issues that people experience and the basis for that science. I will then shift gears and touch on the ways in which cognitive issues differ when the cancer directly impacts the central nervous system. That is, when there's a tumor in the brain itself, either as a primary brain tumor arising from the brain, or in the case of secondary spread of cancers or metastases to the brain. And we'll wrap up by talking about management of those cognitive symptoms and future directions for the field. So starting with chemo brain, I think it's important to know as a neuropsychologist that the concept of chemo brain originated with patients. This was primarily a complaint that was brought by patients to their oncologists and was often dismissed early on. And over time, research has generated enough backing in neuroscience to demonstrate that there is a real neurologic problem going on here. But it took decades for that to occur, and I'm going to review some of how that happened. The short answer to these questions now is that yes, chemo brain is a real thing, real as in neurologic, as well as involving a lot of different body systems and psychological factors. And the question of what causes it is still in a great deal of debate. This is a listing of some of the many kinds of systemic agents that people with cancer are required to take as various parts of their treatment, including a number of these drugs at the top, which fall into the category you might think of as classical chemotherapy, steroids, which affect the central nervous system, anti-angiogenic drugs, which affect the vascular supply for the central nervous system, and more novel therapies, including immunotherapies and hormonal therapies, all of which have known side effects. The biology at a cellular level or molecular level is beyond the scope of what I want to cover today. But what I would like you to know is that at cellular level preparations and animal models, the direct cellular toxicity of these agents has been established. In other words, many of these agents have been demonstrated to destroy neurons, either directly through toxicity or through secondary mechanisms such as inflammatory mechanisms or oxidative stress. They also affect the neurovascular niche and induce white matter damage at a cellular level and destroy the neural precursor cells in the hippocampus and subventricular zone that are known to be important for neurogenesis throughout the lifetime. And ultimately, this pattern, multiple avenues of toxicity, increases risk for neurodegeneration and neural damage at the cognitive level as well. From a neuropsychological standpoint, the studies go all the way back to the 1980s, but it really wasn't until the early 2000s that systematic longitudinal research established the validity of the objective cognitive changes that can occur after treatment with chemotherapy. And I'm going to give you just a couple of examples of these early studies so you can get a flavor for how the studies were done and what some of the complexities are. So this is data from an early study in 2004 conducted by the group at MD Anderson. 18 women with invasive breast cancer that were treated with a multi-agent chemotherapy regimen, abbreviated FAC. And I'm going to pause for a second just to say, many times people ask me, are there specific chemotherapy agents that are known to cause cognitive problems more or less than others? And one of the facts of dealing with chemo brain is that many chemotherapy agents are used in conjunction in multi-agent cocktails, if you will. Or for many patients, they will have a series of different chemotherapy agents given over time. It is very difficult in the clinical literature to separate out the independent effects of these agents. And given the animal and cellular level literature demonstrating neurotoxicity, in many cases, it's not as useful to focus on the specific agent, though there are some offenders that are more concerning than others. In this case, about a third of the patients were noted to have cognitive scores on neuropsychological tests that were below average prior to treatment with chemotherapy. And many of those had cognitive complaints as well. At baseline, most of those tended to be problems with recent memory. But then after treatment with chemotherapy, substantial declines were seen on numerous tests, including tests of working memory, such as digit span and arithmetic, tests of recent memory, such as those here on the visual selective reminding test, the verbal selective reminding test, and the nonverbal selective reminding test indices, all showing declines over time. At long-term follow-up, meaning about a year after treatment, about 50% of patients continued to have deficits compared with their baseline, and about 50% had improved back to their baseline. In a follow-up study using a slightly larger group, again, a multi-agent chemotherapy regimen was used in women with breast cancer, tested both at a pre-treatment baseline, an acute time point, and a later time point about a year later. At baseline, about 21% of patients met the criteria for cognitive impairment in this study, which included the number of tests performed below 1.5 standard deviations below the mean. And over time, these individuals showed further declines and proportion impaired after treatment. 65% of the women showed a decline on at least one test, and 61% showed a further decline at the late time point, meaning about a year after treatment. This was the first study to suggest the possibility of longer term or delayed onset effects of chemotherapy and cognition. And what you can see is that in this particular study, the most substantial declines were seen on Hopkins Verbal Learning Test, TRAILS B, and to a lesser extent, processing speed measures such as TRAILS A. These are showing the declines at the acute time point and then further improvements or declines later on. So it's these kinds of early studies that suggested there were objective performance-based changes in cognition, but the literature was not consistent in every case. And there are a number of design issues and analysis issues that might have contributed to these. For example, in an early study of women with breast cancer who received chemotherapy and radiation, compared with those who received radiation to the chest area only, there were no differences in performance on any cognitive domain. And there was no change in frequency of no difference in frequency of cognitive complaints on a subjective level between these groups. Now, it is important to note that that study was a cross-sectional study, which compared groups of women only at one time point after they received treatment. It did not look at individual changes in cognition compared with their own baseline. In another study that showed a more nuanced pattern of results in this early window of studies, two different chemotherapy regimes were compared to try to determine whether one was more toxic than the other. And what was found by Sana Shagan and her colleagues was that those receiving the CTC protocol showed more frequent declines versus controls, where those receiving the FEC medications did not show as frequent declines. These inconsistencies pointed out a variety of challenges to the literature. Whether the studies were cross-sectional versus longitudinal seems to be an important component. And identifying the definition of impairment. So in the Shagan study, it looked at within subject changes in a longitudinal way, but they required a fairly stringent criteria for their definition of impairment below the mean of the control group to separate groups. In addition, there's a lot of variability in patient characteristics within these studies and variability in the tests used across studies. Another factor that's important in considering the consistency of cognitive effects is the size of deficits within study. So this was a 2009 study looking at chemotherapy-treated patients compared with controls across a variety of cognitive measures. And what you can see here is that in the asterisk, this graph is one that I put together simply from the table of data to illustrate the issue. This is showing you the mean standard deviation in the control group versus the chemotherapy-treated group. And often what is seen are small but consistent effects within the treatment group that do not reach a clinically significant level of impairment in terms of the number of standard deviations below the mean. So we're often dealing with relatively subtle findings, many times in high-functioning individuals who may be experiencing a decline from their own personal baseline that may or may not reach a clinically significant level of impairment from a statistical sense. Indeed, another factor is the measurement of change over time. And in discussing this with Josh and Katie right before this talk, I know that the topic of how to measure change on neuropsychological tests has already been discussed in this venue, and I won't debate the topic to a great deal right now, but even reliable change index scores, which are often used in these studies, do not always account for important factors such as regression to the mean. And for example, in this 2009 study, Weeman et al. Demonstrated that use of a standardized regression-based change model demonstrated a much higher rate of discrepancy or decline between chemotherapy or hormone therapy treated subjects than did the RCI-based measurements of declines. So there are a variety of factors in the objective testing. And another confusing part of this literature is that many of the studies use subjective measures of cognition as their outcome. And as we all know, subjective measurement of cognition is not very well correlated with performance on neuropsychological tests. This has been demonstrated over and over again in a variety of different settings. The data I'm showing you here is just from one example of a recent study done in our group where we were validating a new measure of subjective cognitive function called the FACT-Brain Cognitive Index. And above, you can see the correlation between this subjective measure of cognitive function and other measures of quality of life and familiar measures of mood and anxiety, showing high correlations. But those correlations between our subjective cognitive index and standard neuropsychological tests are quite low. In our group of over 200 subjects, they're statistically significant, but they're not showing a strong relationship. The reasons for this is a topic of debate all in and of itself, whether these subjective complaints are more reflective of depression or anxiety, whether they reflect a problem with insight, or whether it's the objective test that lacks sensitivity to subtle cognitive experiences that are important to patients. That topic is an important discussion, but for the purposes of understanding this literature and gaining consistency, it is critical to agree on what the metrics of cognition are going to be. Meta-analyses have helped us in this direction, and multiple meta-analyses of this literature have been conducted over the past 15 years or 20 years. I'm not going to go into these now, but to summarize, 9 of 10 of these have come to the conclusion that cognitive deficits, as measured in one means or another, are associated with chemotherapy treatment. So which cognitive abilities are most affected? Well, that is a matter of some discussion as well. Broadly speaking, as we look across the studies, it's common to see deficits in information processing speed. Potentially all aspects of recent memory can be affected, working memory, and different subtests of executive function. These multiple cortical and subcortical regions involved in these cognitive processes indicate a diffuse frontal subcortical etiology, but there's also reason to believe there's potential special sensitivity of the hippocampus related to some of the recent memory findings. And as I mentioned earlier, there has been a body of animal literature demonstrating the toxicity of chemotherapy agents for neural precursor cells, which we believe are important in hippocampal neurogenesis. So this is a diffuse systemic type of problem. The neuroscience literature that has integrated neuroimaging has taken us a step farther in understanding some of the mechanisms and processes that are likely involved in chemotherapy-related neurotoxicity. And I'm going to touch on a couple of these. At a structural level, several studies have shown reduction in gray matter volumes or gray matter thickness related to chemotherapy treatment. So for example, in this early study by Brennan McDonald and colleagues, there was a specific area of gray matter density shown to decline between baseline and 1 month post-chemotherapy that was not present in a matched group of control subjects in the left frontal lobe. A cross-sectional study by Shelley Kessler and colleagues demonstrated difference in hippocampal volume between patients who were treated with chemotherapy and other breast cancer patients who had not had chemotherapy. And those differences were found exclusively in hippocampal volume, not correlated with whole brain volume. And the hippocampal volume differences correlated with performance on standardized memory tests, again, suggesting the potential for a special relationship with the hippocampus. Measures of connectivity have also shown, the structural connectivity metrics have also shown differences either before and after treatment, as in this Denise Correa study in 2016, which showed decreases in mean and axial diffusivity in a number of regions of interest that occurred 1 year after chemotherapy. And in another study from Shelley Kessler et al. Showing that breast cancer alone was associated with reductions in connectivity throughout a widespread network of brain regions, even prior to treatment with chemotherapy. Functional metrics of connectivity based on fMRI have also shown similar reduced connectivity in patients with breast cancer, both prior to and after treatment. Perhaps the most interesting study of connectivity in the cancer and cognition literature was conducted by Sabine Desprez and her colleagues in France. They used diffusion tensor imaging, which, as most of you I think are aware, measures the integrity of fiber bundles in specific areas of the brain, and looked longitudinally, comparing breast cancer patients who did versus who did not need chemotherapy, as well as a matched control group. The cognitive assessment did show a reduction in AVLT learning scores and DigiSpan scores between the chemotherapy treated groups and the other two groups. And on the diffusion tensor imaging, there were reductions in integrity in frontal, parietal, and occipital lobes that occurred from pre to post chemotherapy treatment. And in fact, some of these regions of interest found to show reductions in connectivity also correlated with performance on the cognitive assessment. So there was a reduction in fiber integrity that correlated with memory decline or working memory decline. But perhaps most interestingly, in a follow-up study published in 2018, in which the subjects who have participated in the early study returned to be re-imaged and repeat testing 3 to 4 years post-treatment on average, there was a recovery of function seen on all of the tests of memory and processing speed with return to baseline levels of performance. And perhaps more strikingly, improvement in the fractional anisotropy metrics returning to baseline in all 4 of the regions of interest in which a decline was identified previously, suggesting that there may be long-term potential for remyelination or recovery of function through some mechanism after chemotherapy. Functional brain imaging literature has also lent additional information to our understanding of chemobrain. This was a very clever retrospective study that was conducted by some of my colleagues here at MGH, in which patients who had undergone standard PET imaging, this is FDG PET, fluorodeoxyglucose, which looks simply at glucose metabolism, And patients with cancer are often scanned with PET to identify areas of high glucose uptake that may be growing tumors throughout the body. Dr. Dietrich and his colleagues were able to extract brain PET images from a number of individuals who had gone through chemotherapy treatment for a cancer elsewhere in the body, but then went through routine PET scanning before and after treatment to scan for additional tumor growth, and found that in the subjects they were able to scan both pre and post, an average change of 44% in glucose metabolism throughout the brain. And a number of areas were affected, particularly widespread gray matter areas showing decreases in resting glucose metabolism. Functional brain imaging during cognitive activity has shown a more nuanced pattern, but one that is somewhat familiar from other areas of neurology. On the left, I have here an fMRI study during which an individual patient who had been treated with chemotherapy and her twin sister were exposed to a working memory paradigm. One of these images was from the patient with chemotherapy treatment, the other was from her sister. You can see that the image on the left has a wider spread of activity in brain areas throughout the parietal and frontal lobes, often associated with working memory. The patient on the left, the subject on the left, is the cancer patient treated with chemotherapy, showing a wider spread of activation than her twin sister performing the same task. In a similar study early on in the functional imaging literature in this area, a PET study, in this case showing differences between chemotherapy-treated subjects and control subjects during a memory task, a similar greater extent of activation was seen in chemotherapy-treated individuals. And that pattern has been replicated in a number of different studies, showing hypoactivation in a number of cortical areas, or I'm sorry, hyperactivation in a number of cortical areas and hippocampus during a variety of different kinds of cognitive tasks. Here's another example from Sana Shagan's group recently. And the important figure here is in the middle. These regions of interest are examined in this bar graph. And what you can see is that the breast cancer patients who had systemic therapy are showing a much greater level of activation than patients with breast cancer without systemic therapy or healthy controls. And in fact, an interesting finding in this case was the possibility that there was a suppression of activation in the breast cancer untreated group. In any case, this hyperactivation is often thought of in a number of other neurologic groups as a potential compensatory mechanism, raising the question of whether part of the cognitive mystery, if you will, of the chemo-brain problem. In other words, this idea that we're seeing subtle cognitive changes and patients are complaining of significant cognitive changes, may reflect the possibility that that compensatory brain activity is somewhat effective at performing the cognitive task, but it's taking a great deal more work to do so. This finding is a topic of great interest in the cognitive neuroscience literature and chemo-brain now. One other topic that is of significant interest is whether chemotherapy exposure places people at risk of accelerated aging from a cognitive standpoint, whether it enhances risk of neurodegenerative disease. And this concept is currently under exploration in a number of longitudinal grant projects. Suffice to say, there's mixed findings right now that we'll need time to sort out, but it is an area of concern. The leading voice in the chemo-brain world is the International Cognition and Cancer Task Force, and they provided guidance for both the use of neuropsychological tests in this research and the neuroimaging parameters that are recommended to try to harmonize the outcome measures that are used and improve the methodology of these studies. When it comes to their specific recommendations for neuropsychological tests, which is in this 2011 paper here, which I would think of as recommended reading for anyone seeing patients with chemotherapy-related cognitive concerns. The ICCTF stopped short of recommending any kind of clinical battery. Note that these are recommendations for research in cancer and cognition, but they did recommend the use of appropriate neuropsychological tests that have the advantage of being valid, repeatable, and sensitive to the measures in question, and name some specific neuropsychological tests that we're all familiar with. So what I want you to take away from this discussion of chemo brain is that there is clear evidence of cognitive change that occurs both in the context of cancer and maybe further exacerbated by treatment with chemotherapy. The domains, as I've said, appear to be widespread and reflect frontal subcortical networks and possibly hippocampal damage. That's been borne out in this neuroimaging literature, both in terms of structural neuroimaging, connectivity, and brain activation. And finally, on a hopeful note, there is some reason to believe that some recovery of both structure and function may be possible, but the longer term consequences at this point and whether or not there is a link between chemotherapy exposure and neurodegenerative disease is unknown at this time. So let me pause there for a moment and see, I don't know, Josh, if you have questions you'd like to address at this point, or if we should carry on.
Sure. There's two questions in the chat right now, which I feel like we can talk about now very briefly and then save the rest of the 25 minutes for the second half of your talk. The first question we got is, one of the questions we got is, if many chemotherapeutic agents do not cross the blood-brain barrier or have poor penetration, why do we see such profound effects on gray matter and connectivity after post-chemo treatment, even in patients with non-CNS cancer?
Yeah, that's a great question. I think that there are a lot of hypotheses about that, and I'll just go back to this slide here, which speaks a little bit to some of the cellular level mechanisms, whether or not the neurologic injury is mediated by inflammatory cascades. Looking at specific cytokines like IL-6 and IL-8 have been of interest, or other manifestations of oxidative stress is still not completely mapped out. But that's certainly one of the main hypotheses. The effect on the neurovascular niche, which may be vulnerable to some of the chemotherapy agents and is at the boundary of that blood-brain barrier, is another topic that is particularly implicated in its relation to the hippocampal involvement or the neurogenesis issue.
Great. The other question, just quickly, is there any literature that you're aware of or any comment on this, of if cognitive impairment and or structural differences may be exaggerated from stress or, like, for example, like PTSD from undergoing cancer treatment?
I'm not personally aware of literature that's been able to separate those factors out. I think that it is inherent in a lot of the literature that the experience of dealing with cancer is a stressor in and of itself. And we know that stress operates through some of these same mechanisms to influence neural structures and pathways. So it's an important question, but one that's difficult to parcel out. Part of the way that the studies have tried to separate that is to use control groups that are individuals who've experienced cancer but maybe didn't have the chemotherapy treatment. So they will have undergone surgery, perhaps radiation to a non-brain area, and using that cancer control group is an attempt to parcel those factors out. The reality is we, as I said, see that there are some neurocognitive effects of cancer itself that seem to be greater or exacerbated in many cases by the chemotherapy agent. So I think that the answer is both are probably factors to differing degrees.
Sounds good. This is hard to investigate, as you say, for sure. Why don't you go ahead then and move on with the second half, and then we can do a few more Q&A, hopefully around 3:55 Eastern. Okay.
Perfect. Okay. So the topic of brain tumors is really the topic of multiple lectures. My goal here today is to simply touch on some of the vocabulary and make sure that people are thinking about some of the specific ways in which brain tumors affect structure of the brain. I know that a lot of the folks here on this seminar probably have experience seeing patients with brain tumors. Others may not. And I want to touch on some general topics. But my goal has been for a long time to try to educate about the different subtypes of brain tumors and all their various nuances so that neuropsychologists can get comfortable with brain tumor groups and participate in the care of brain tumor patients along with cancer center physicians, surgeons, and other professionals. So it's perhaps no surprise to this group to point out that neurocognitive impairments in patients with brain tumors are very common. Depending on how you measure that cognitive symptom, different studies show prevalence rates of up to 90% of cognitive symptoms in one level or another in patients with brain tumors of various sorts. And the impact, the way in which brain tumors cause those cognitive problems are very widespread. Of course, the tumor itself and edema surrounding it can affect the brain regions that are impacted, as well as disrupt connectivity to distant brain networks. The volume of metastatic tumors or primary brain tumors is strongly predictive of the likelihood of cognitive impairment, as I'll show you in more detail in a minute. Of course, tumors also cause other neurologic problems such as hemorrhage, edema, and seizures, all of which can disrupt cognitive function. And then treatment is usually required, meaning surgery, chemotherapy, as we just discussed, radiation. And then there are indirect effects of cancer on the neurologic systems as well, such as paraneoplastic syndromes that add another layer of complexity. One of the more interesting ways in which neuropsychology has played a role in brain tumor treatment and care at a medical level is demonstrating the relationship between cognitive symptoms and overall outcome or prognosis for patients with brain tumors. And that objective measurement of cognition has been shown to add useful information. Now, I'm going to talk about brain tumors very broadly speaking, but it's important to know there are many different types of brain tumors. Each of them has their own course, prognostic factors, and treatment variables. It's a lecture in its own, actually a 3-hour seminar to go through and talk about each of these different types of brain tumors and how they might affect cognition in different ways. But we'll be talking in general terms about a number of different types of tumors here. One of the important things to do as a neuropsychologist working with these patients is to familiarize yourself with some of the vocabulary of oncology. And let me just say, it's complicated. This is a list of molecular markers, genetic features of brain tumors that are important in the prognosis of the disease itself, and also have relationship to the likelihood of cognitive symptoms. Many of these markers, which come from pathology examination of the brain tumor tissue after it's resected, relate to gliomas, or primary brain tumors that arise from glial tissue. And as you can see, and markers such as the IDH mutation, which I'll talk about more in a minute, can give you differing prognostic factors and affect survival and cognitive outcome. The problem with these terms is they're very confusing. It's an alphabet soup situation where going in as a neuropsychologist, these will be very unfamiliar terms. So working through and learning about each of these does take a good deal of time and built into training, ideally, as you get the opportunity to get supervision working with these patients. But they are important variables. This graph here shows overall survival of a number of subtypes, people with subtypes of gliomas that are stratified by those different markers. The IDH mutation or the deletion of the 1p19q gene or 1p and 19q chromosomes significantly separate out overall survival in this large pathological outcome study, showing that those folks who are in group 4, or the glioblastoma subtype of gliomas, have median survivals in the area of 16 to 18 months, whereas those in this group 1 group have median survivals in the time of 12 to 15 years. So it's very significant impact, and it's important to understand what those things mean when the patient comes to you, because it may have a very significant impact on what your role is as a neuropsychologist working with that patient. As I mentioned, cognition has been shown to be a predictor of brain tumor progression and overall survival in research that was generated out of the MD Anderson Cancer Center more than 20 years ago by Christina Myers and others there. This graph simply shows that decline on cognition preceded progression in this large study of patients with glioblastoma. In this case, progression was identified at this time point in subjects with using neuroimaging, but decline on a first cognitive test was detected at an earlier time point in each of these subjects and shown to be highly correlated with progression. That finding has been replicated a number of different times, including in this study from 2012, showing that decline on different numbers of tests correlated with progression and overall survival in this population of GBM patients. And again, in another study released by Jeff Weffel last year, showing a relationship between cognitive impairment and progression of GBM. So what causes that cognitive impairment and how does it relate to the underlying disease? We've known for some time that tumor grade, or the speed of growth of gliomas, causes more rapid tumor growth, causes more cognitive impairment, even when controlling for tumor location and size. The high-grade tumors are more likely to produce cognitive symptoms, in this case stratified by grade 2, grade 3, or grade 4. And in the more recent era of molecular testing that more accurately separates out brain tumors by prognosis, what's been shown is that the IDH wild-type tumors, which are a more aggressive phenotype, are more likely to be associated with cognitive declines on a number of tests, including things like HVLT, TRAILS, even the pegboard test, more likely to be disrupted by IDH wild-type tumors than IDH mutant tumors, the slower growing variety. So the momentum tumor growth rate causes more cognitive problems, perhaps because slower growing tumors leave time for the brain to reorganize. There are also individual difference factors that have been shown to be related to the presence of cognitive symptoms, regardless of tumor location or tumor size. Most of this work has been done by Denise Correa at Memorial Sloan Kettering, showing relationships with ApoE, as well as a number of other genetic polymorphisms that we know to be related to cognition in neurologic disease. The impact of treatments on cognitive outcome is an area where neuropsychologists often play a role. And this has to do with when in the process of tumor identification, diagnosis, and treatment is the neuropsychological evaluation conducted. Neuropsychology has been shown to have a very useful role at the time of surgery in the case of glioma and to some extent in brain metastases. While surgery can have a beneficial effect on cognition for a patient with a brain tumor by removing the mass and reducing the edema, there are, of course, also risks of surgery. And integrating functional MRI, diffusion tensor imaging, neuropsychology with intraoperative mapping can be a useful way to identify cognitive risks and optimize cognitive outcomes. I'm putting in a plug here for David Sabsovitz's monthly Neuropsychology Surgical Mapping Conference. If you haven't attended these, David distributes the announcement. It's free to all to attend, and he takes a very deep dive into individual cases in which neuropsychological assessment, functional and structural brain imaging, and intraoperative mapping are used to identify cognitive risks and optimize outcomes. This has also been published in the literature, and I'll just give you an example of one study here, try to walk you through the steps. This is a group in France that has, across multiple studies, demonstrated the potential for brain reorganization in response to tumor growth in adults. So in panel A, what you can see is a mass lesion in the left frontal lobe and an area of brain activation on a language task immediately posterior to the brain mass. In intraoperative mapping, this area here was identified as an area that caused speech arrest and correlated with this area of activity, but was involved with tumor. During surgery, the decision was made to stop the operation, leaving behind some residual tumor. And over time, functional MRI was repeated. This image in imaging in panel C shows that the area that was previously active was left intact with some tumor involvement. Follow-up functional imaging is shown in panel D, and in this case, the same fMRI task showed increased activity in the contralateral hemisphere and in an area posterior to where the previous study had shown activation, comparing to image A. The surgeon was able to do an additional resection, now removing the area that previously had shown language activation, which now in the second surgery 2 years later did not produce speech arrest, and was able to achieve a gross total resection without inducing a language deficit. The whole time course suggesting that over the evolution of this tumor, language had reorganized more posteriorly, and they were able to achieve a safe resection. Another treatment modality commonly used in brain tumors is radiation therapy, which is known to have substantial neurocognitive impact and neurotoxic damage. The risk factors for cognitive decline as a function of radiation therapy are numerous, but in particular, the larger amount of radiation delivered in each dose and the older age of the patient are clearly the strongest total predictors of the likelihood of developing neurologic impairment. When combined with chemotherapy, which is usually the case in brain tumors, there does seem to be an exacerbation of risk. And the presence of individual risk factors such as cerebrovascular disease or some of the genetic polymorphisms we discussed earlier may also interact to predict the risk of neurologic injury from radiation. Radiation is another technique that has been shown to damage myelin, the neurovascular niche, and destroy neural stem cells in the hippocampus, the granular cell layer of the hippocampus, and the subventricular zone, which may also underlie some of the progressive neurodegenerative changes that can be seen. And eventually, radiation therapy can produce late onset additional tumors by virtue of causing mutations that come years after the original treatment. We know that the neurotoxicity of radiation therapy is widespread, not just in the areas that were directly in the field of radiation, but throughout the brain. In this case, a study from the MGH group showed that there was increased ventricular size and reduced gray and white matter volume occurring throughout the brain, including in the hemisphere contralateral to a radiation therapy target for a brain tumor. That progressed over 2 years after treatment. Radiation therapy strategies have been developed to try to reduce the amount of neurotoxicity from radiation, including using stereotactic radiosurgery, where focused beams of radiation target specific small areas, using intensity modulated radiation therapy, to reduce from whole brain treatment whenever it's not necessary. Using protons instead of photons as the means of treatment, which, as shown in this image, produce a much tighter field of radiation therapy and much less overspray, as we see in photon radiation therapy. And finally, using hippocampal avoidant whole brain radiation therapy in those situations where whole brain radiation is required to try to reduce some of the toxicity to those neural progenitor cells that I mentioned. Recent studies have integrated the use of neuroprotectant medication, in particular memantine, as a treatment to try to reduce the neurotoxicity of radiation therapy with some modest effect. In these two studies, one of which included hippocampal avoidant whole brain radiation therapy with or without the memantine, and one simply looking at memantine alone, both showed a similar effect size that a group of subjects appears to be spared this rapid decline in cognitive function that occurs after treatment through treatment with memantine. So memantine seems to have a protective effect on a subgroup of patients. There have been a number of other studies looking at pharmacologic agents, including trying to use Aricept, stimulant agents, wakefulness agents such as modafinil and methylphenidate in patients with chemotherapy related cognitive problems and brain tumor. And it's beyond the scope of this discussion today to go over all of these. But if you're interested, I can refer you to this review that we did a couple of years ago that touches on both the history of that literature and ongoing studies. Cognitive rehabilitation and other non-pharmacologic interventions have also been explored. While these efforts have included relatively large groups, there are still a number of limitations to these studies that essentially have led to limited indication of benefit at this time. Those have included computerized cognitive training programs, such as this early study by Shelley Kessler, showing that training did improve performance on executive function tasks compared with a waitlist control group, but very little evidence of generalizability to other non-practice tests. I'll point out this recent study that just came out from Sarah Braun's team at Virginia Commonwealth University, in which they used the CogMed working memory training to evaluate treatment for cognition in glioma patients, and found that the adherence to treatment was relatively low. Although patients showed a benefit in performance, their subjective sense of benefit was somewhat less than the demonstrated improvement on cognitive testing, suggesting that the burden of treatment, which was 5 days per week for an hour, outweighed the benefits they perceived. I'll stop here just by saying that it's incumbent upon us as neuropsychologists, I think, to educate our patients about these issues. As we know in this and many other areas, there's lots of advertising going on about these kinds of tools that will potentially treat cognitive problems. And in the context of dealing with a brain tumor, I think it's important for patients to be aware of what the possibilities are for management of these cognitive problems and what kinds of issues are better treated through cognitive rehabilitation that provides adaptive strategies. So I'm going to stop there before we run it completely out of time and see if there are any questions about these brain tumor topics. Now I can talk a couple minutes about practice model type of issues.
Sure. We're close to the top of the hour too. I know lots of people, maybe even yourself, have to run. Maybe in terms of practice model, maybe we can do a future lecture on that just to save the time for the other folks. But I appreciate, Dr. Parsons, your great enthusiasm for that topic as well. Let me just ask a couple of questions, if that's okay with you, about the topics that you were just discussing. So we have a question. I feel like you might have touched on this a little bit, but maybe you can re-highlight this. what resources would you recommend in terms of various agents like medications or radiation therapy on cognitive function? You said, I think you said, mentioned a literature review, or are there certain resources where our interested viewers should turn to?
Yeah, absolutely. This is just one. There are several of these reviews. In fact, there were two excellent reviews of cognitive rehabilitation and pharmacologic strategies in brain tumor patients specifically, that came out in 2019. The literature, as I said, is pretty broad. I do think that the takeaway message for me from the medical medication-based treatments is that there are a subset of patients who seem to get slight benefit from methylphenidate or Aricept when the cognitive profile fits what we expect the mechanism of action of the drug to be. In other words, if you have a patient who you assess who clearly has primarily recent memory deficit that appears to be an encoding or possibly consolidation, then using acetylcholinesterase inhibiting medication like Aricept, donepezil, may be a reasonable strategy to consider. And that was borne out to some extent by this study by Rapp and colleagues in 2015. Similarly, the placebo-controlled studies of methylphenidate have generally shown very mixed results, but there are reasons to believe that part of that is because many of those studies showed a pretty substantial benefit from the placebo, as many as a third of subjects getting a benefit from placebo. So if you have a patient who clearly has an attention working memory type of pattern, and it's medically safe for them, it's not unreasonable to consider a trial treatment with a stimulant medication, obviously working together with the patient's physician, to appropriately discuss that issue with the patient.
Yeah, thank you so much. Just in terms of time, so like I mentioned, it'd be great to have you come back and talk about the practice model. For anyone, so as a question, just sort of broadly speaking, because as you mentioned, right, even the lecture where you mentioned the different types of brain cancers, that would be a 3-hour webinar in itself. Are there, to your knowledge, from either like NAN or INS, are you aware, or books, any like sort of a key resource you'd recommend if somebody wanted to start learning now about sort of the neuro-oncology piece they could turn to?
That's a great question. It's one that it's sort of on my to-do list of things that we should really put together, because I don't honestly think there is a good resource directed at neuropsychologists that helps to unpack a lot of the details about, say, different types of brain tumors, what their course is, what their treatments are, what to expect. I think it's most of that material is embedded in review articles, which I'd be happy to share with any interested person, or similar types of topics. It's really a short book that needs to be written, a review of brain tumors for non-physicians, so that you can get the vocabulary and get the basics and start to work with these patients.
Great. And maybe if you don't mind, I can work with you in the background, Dr. Parsons, to put together a
to
few
write that book.
No,
Yeah,
not to write the book.
Yeah, that's thank
I
you,
would, I'm not
Josh.
even really an
Really
expert on this. I was
appreciate
going to say to post a
volunteering.
few of these resources to our, hopefully we can post maybe your review article and a couple other articles to the website to accompany the recording.
Absolutely.
So I'll cut us off there just because we're at the top of the hour. But thank you so much, Dr. Parsons, for coming and joining Neuropsychology today. Hopefully we can have you back, because it's a huge area of interest and lots of different information that we can learn as neuropsychologists and neuropsychology trainees. So thank you for coming and talking to us today. I'll just mention for everybody who's still on the call that next week, the Neuropsychology lecture will be at 2 p.m. Eastern or 11 o'clock Pacific time. And it'll be on the path to pediatric clinical neuropsychology. And we'll have a panel featuring 3 pediatric clinical neuropsychologists, Dr. Lee, Dr. Berrios, and Dr. Vega, who will be joining us to talk about their different routes to becoming a pediatric clinical neuropsychologist. So thanks for joining us again, Dr. Parsons, and everybody.
Thanks so much for having me.
Yeah, sounds good. Bye-bye.
Bye-bye.